Hey, good evening, guys. My name is Alec. I am a physician assistant student at Mount Union, and I have a really cool microphone. And I am going to be presenting on my capstone project tonight, which is called Colchicine for COVID-19, an ancient drug for a modern disease. And here is the table of contents. Wanted to give you guys a quick overview of what's coming. We've got the introduction followed by clinical vignette, physician assistance, and colchicine as a COVID-19 treatment, the origins of SARS-CoV-2, the spread of SARS-CoV-2, the pathophysiology of COVID-19, the COVID-19 induced hyperinflammatory state, and the therapeutic potential of colchicine, followed by the methods, results, discussion, summary, limitations, risks associated with colchicine, implications, and recommendations. Starting off here, I'm sure we all know by now that COVID-19 is a big deal. From personal to national levels, the coronavirus disease of 2019 has changed how billions of people across the globe operate. COVID-19, as we know, is a disease caused by severe acute respiratory syndrome, coronavirus 2, also called SARS-CoV-2. It was first discovered in Wuhan, Hubei province, China, in December 2019, and unfortunately, effective and widely available treatments have yet to be established. As of July 10th, 2021, yesterday, there have been 185 million confirmed cases of COVID-19 worldwide, over 4 million attributable deaths, and more than 200 countries infected. So you may already know, but the course of COVID-19 can vary pretty greatly. It can be completely asymptomatic, or on the opposite end of things, it can lead to acute respiratory distress syndrome, or ARDS, organ failure, and death. And we'll get into this more later, but studies have shown that a hyperinflammatory response to COVID-19 is responsible for the moderate and severe disease as we understand it now. So without further ado, let's get into our clinical vignette. So chief complaint is COVID-19. And this is a 71-year-old Caucasian male, we'll call CD, with a history of diabetes mellitus, hypertension, myocardial infarction, and chronic obstructive pulmonary disease that presents for a virtual appointment with changed cough and fever times 2 days. Last night, he felt feverish and developed a cough. He found his temperature to be 102.4 degrees Fahrenheit. He has since taken 325 milligrams Tylenol every 4 to 6 hours without recurrence of the fever. The same night as symptom onset, CD decided to get tested for COVID-19 via nasopharyngeal PCR, which came back positive for SARS-CoV-2. He also reports diarrhea, myalgias, headache, and loss of smell and taste since this morning. He made the appointment today because he is afraid of what will happen to him as the COVID-19 progresses. He had a friend recently pass away from COVID-19, and he understands his diabetes, hypertension, and COPD put him at higher risk for severe disease. He does not believe in vaccines, and he did not receive one for COVID-19. He denies shortness of breath, blood in the stool, and states he has been staying adequately hydrated. All right, so moving into his past medical history here, CD had bacterial pneumonia in 2019, for which he was given antibiotics and hospitalized at St. Joe's for 7 days. He had a myocardial infarction in 2015 with 2 stents placed. He follows with Dr. Jansen in cardiology annually. For chronic illnesses, he's got hypertension, managed with hydrochlorothiazide, diabetes, managed with metformin and Invokana, COPD, managed with 2 liters of oxygen via nasal cannula at home and an albuterol inhaler. Hospitalizations once in May 2015 for the cardiac stent placement post-MI, once in August 2019 for the bacterial pneumonia that we talked about. And the medications that he's on are the hydrochlorothiazide, 50 milligrams PO BID, metformin, 500 milligrams PO BID, which means by mouth twice daily, Invokana, 200 milligrams PO Q day, by mouth every day, once a day, albuterol, 2.5 milligrams inhaled every 4 to 6 hours as needed. For social history, CD lives in an apartment with his dog Rufus. His wife passed away 7 years ago, and he has no family members in the state. CD likes to sit on his porch when the weather permits. He also enjoys playing poker with some friends once a week. Okay, so on review of systems, CD admits to chills and fatigue for general. For HENT, he admits to a loss of sense of taste and smell, rhinorrhea or runny nose. He denies sore throat, changes in vision or hearing. He admits to changed productive cough that's different from his typical cough that he has with the COPD. Denies dyspnea, wheezing, excessive use of rescue inhaler. For gastrointestinal, he admits to diarrhea, denies hematochezia, melena, nausea and vomiting, and abdominal pain. For cardiovascular, he denies chest pain, palpitations, history of pulmonary embolism. For musculoskeletal, he admits to generalized myalgias, denies arthralgias. And for neuro, he admits to a headache but denies changes in thinking, facial droop, and ataxia. On physical exam, CD is a 71-year-old ill-appearing male that appears his stated age as visualized via telehealth video session. He appears anxious but not in acute distress. His exam is limited due to virtual appointment. His vitals, his respirations could be counted at 16 per minute. For HENT, he had a grossly intact head, face, neck, no edema or cyanosis noted. And for pulmonary, he did not appear to have labored breathing. There were no signs of accessory muscle use or retractions. All right, so on to the assessment and plan. Number one is CD's COVID-19. He was counseled regarding monoclonal antibody options. The closest infusion center is a 4-hour drive from CD, and unfortunately he is not interested in making the drive or investigating that option further. CD was instructed to go to the emergency department with new or worsening symptoms, including increased use of rescue inhaler and or shortness of breath. For his COPD, he was instructed to continue home oxygen and rescue inhaler as needed. For diabetes, continue his metformin and Invokana, and for hypertension, continue his hydrochlorothiazide as prescribed. So you can see from this situation that unfortunately there's no good way to go about this, right? We have an individual who is at high risk because of his age and multiple comorbidities, and the monoclonal antibody option is not ideal for CD. And he is anxious. It would be really nice if we could offer him something here, right? So that is a great transition into my research question. What are the effects of colchicine on the severity and mortality of COVID-19? Colchicine is a well-known anti-inflammatory drug that's often used for treating gout, but does have some other off-label uses as well. Its properties could make it a promising therapeutic agent for the hyperinflammatory state that is induced by COVID-19. And that is, again, something that I'm going to go into more detail on. Colchicine can be prescribed outpatient and is generally very well tolerated with no serious adverse effects. So it'd be really great for an outpatient setting in theory. PAs, physician assistants, and colchicine as a COVID-19 treatment. So PAs were originally created in the mid-1960s to help fill a gap created by a shortage of doctors in the U.S. PAs collaborate with physicians while seeing patients, making diagnoses, and offering treatment, including prescriptions. Research has found primary care delivered by PAs has comparable outcomes to their physician counterparts. Awesome. PAs have a generalist education and can practice in any area of medicine, including infectious disease, emergency settings, and critical care, which are all very important in the pandemic. And as it is true for other medical providers, such as physicians and nurse practitioners, the effectiveness of colchicine as a treatment for COVID-19 is relevant to many areas of PA practice. So let's talk about the origins of SARS-CoV-2. SARS-CoV-2 is widely believed to be zoonotic in origin, probably from bats. And in fact, most diseases infectious to humans originate in animals, including measles, influenza, dengue, and human immunodeficiency virus, or HIV. SARS-CoV-2 is from the genus beta coronavirus, and one study done in 2017 of over 19,000 wild bats, non-human primates, and rodents across 20 countries found that 98% of beta coronavirus positive samples came from bats. A virus called bat-CoV RATG13 actually has a genome that is 96.2% identical to SARS-CoV-2, which is very impressive, and was found in the species of horseshoe bat, Rhinolophus affinis, which lives in various parts of China. SARS-CoV-2 uses the angiotensin-converting enzyme 2 receptor, ACE2, to enter human cells. And bats possess an ACE2 cell receptor that is very similar to the one that we see in human cells. And at the time of outbreak, bats were sold at the Huanan market near Wuhan, China, for consumption. So we see the pieces are starting to come together for the most popular theory on the origin. Early in the pandemic, some people thought that civets and pangolins may have had a role in the chain of transmission. Civets were thought to be involved in the SARS-CoV-1 epidemic of 2002 to 2003. However, more recent phylogenetic analysis and various methods of animal sampling indicate that pangolin and civet involvement in transmission is unlikely. Therefore, many researchers believe that SARS-CoV-2 originated in bats and was transmitted at the Huanan wet market in China in December of 2019. And we're going to look at that. So the first patient to be infected with SARS-CoV-2 is still widely debated, but it is known that Dr. Zhang, I'm really sorry about this, Dr. Zhang Jixian, reported 4 cases of unusual pneumonia at a Wuhan hospital to the local health department on December 27, 2019. More cases arose, and on December 31st of 2019, the World Health Organization was alerted. By January 7, 2020, SARS-CoV-2 was identified and initial test kits were created on January 12th. China confirmed 330 mainland cases by January 21st, which rose to 17,000 within 2 weeks. And by January 30th, the virus had been identified in several other countries, including the US, and the WHO declared the virus a public health emergency of international concern. So transmission was found to occur through aerosol droplets, close contact, and potentially fecal-oral contact. Governments around the world sprung into action. And I'm sure you guys probably remember this, but within weeks of discovering this virus, governments began taking action to mitigate the spread, including putting quarantine and social distancing measures into practice. Though putting these into practice varied by country. But these practices have been shown to slow the spread of the virus greatly. Here is a nice little timeline of what we just talked about. First year of the COVID-19 pandemic, so we see the first cases show up in Wuhan in December 27th. And by April 3rd, this is newer information, by April 3rd of 2020, the US reported more than 200,000 cases, and Spain and Italy each reported more than 10,000 deaths attributable to COVID-19. And then the box there that my big head is blocking out says that by January of 2021, there were over 100 million COVID-19 cases recorded worldwide, over 20 million being in the US alone. So another quick shout out to PAs here. PAs have had many opportunities to help slow the spread of COVID-19. They employ mitigation practices in clinical settings and have been the people that get to teach these mitigation practices to patients too, that they can apply on an individual level. And in 2019, there were 139,688 certified PAs in the US, caring for more than 9.5 million patients per week. So I think that gives a pretty good idea that PAs are very involved in this process, and even down to the finer details like helping to stop the spread of SARS-CoV-2 on individual levels. So now we're going to talk about the pathophysiology of SARS-CoV-2. The virus is made up of four main glycoproteins: the spike protein, the membrane, the envelope, and the nucleocapsid proteins. The virus begins invasion by binding to the ACE2 receptor via the spike protein. And no surprise, the ACE2 receptor is found in many human tissues, including the kidneys, heart, thyroid, testes, adipose, small intestine, and most notably the lungs. We're going to talk about that more in a little bit. The virus frequently begins by invading cells of the upper and lower respiratory tract, and alveolar epithelial type 2 cells, which are in the tract there, make up about 83% of total ACE2 presenting cells. So that gives us an idea why the respiratory effects of the virus are so severe. So following the binding of the S protein in the ACE2 receptor, the S protein is primed by host proteases, transmembrane serine protease 2, and or furin-like proteases. That's a mouthful. So the virus actually uses some of the cell's native machinery to bind and fuse with the cell, allowing viral entry. And so once entered, the nucleocapsid is delivered to the cytoplasm of the host cell. And then replication occurs, and viral particles that are a product of replication are transported outside the cell via vesicles. And once outside the cells, the newly made viruses go on to infect other cells. This process commonly leads to the development of anosmia, fever, cough, shortness of breath, and myalgias, but there may be no development of symptoms. And this development of symptoms is a very important point to be examined later on. It is believed that progression from mild to severe disease occurs when the host enters a hyperinflammatory state, which is kind of that progression that we're talking about. And I want to stop and take a second here to note that this pathophysiology is really tough, even for medical providers. And many patients may not have the educational background to understand it. And medical providers, like PAs, are equipped to explain these medical concepts in lay terms, which can help curb anxiety and the panic in what's been one of the most uncertain times in history. Alright, so the virus can cause cell death in a lot of different ways, including pyroptosis of the airway epithelial cells. Pyroptosis is a highly inflammatory method of programmed cell death in response to infectious invasion. And pyroptosis includes many inflammatory signals and activation of inflammasomes, which are cellular constructs that are the first domino in what is a long row of inflammatory signaling. And downstream, this increases levels of circulating pro-inflammatory cell signals, which include interleukins IL-6, IL-2, IL-7, as well as tumor necrosis factor and many others. And increased levels of these inflammatory agents have been implicated in immune system dysregulation and increased severity of COVID-19. And so another aspect to this hyperinflammatory state is that these inflammatory agents lead to excessive pulmonary recruitment of immune cells such as neutrophils, macrophages, and T cells. And these immune cells can then release reactive oxygen species and proteases that damage lung epithelium. And so normally these cells work really well, but in this hyperinflammatory state, it's kind of like a big backup on the highway, and then people get out of their cars and start fighting, or I guess you could say damaging the highway itself. And so the hyperinflammatory process can progress to the development of ARDS, or acute respiratory distress syndrome, like we talked about before, which is the leading cause of death from COVID-19. This unrestrained inflammation is believed to be the cause of much of the extrapulmonary involvement as well. And the extrapulmonary involvement has received less attention in research and is not quite as well understood, but there is still a lot that we know about it. So I'm going to summarize involvement by organ system. So we have cardiovascular, we see myocarditis, pericarditis, vasculitis, cardiac arrhythmias, and heart failure due to COVID-19. Hematologic, we see hypercoagulability, which leads to an increased risk of pulmonary embolism, stroke, and MI. And according to Bon et al., listed in my references, many mechanisms likely contribute to the induction of this hypercoagulable state, including increased procoagulant neutrophil extracellular traps called NETs and cytokine-mediated vascular damage that leads to monocyte recruitment, activation in tissue factor exposure, which in turn increases coagulation. Gastrointestinal, diarrhea like CD had, nausea, vomiting, abdominal pain, liver injury, pancreatic injury and dysfunction. Renal system, we see renal injury and failure. Neuro, we see headaches, brain fog, dizziness, confusion, Guillain-Barré syndrome, acute encephalitis, infectious toxic encephalopathy, and acute cerebrovascular attacks. And these neurological sequelae seem to be explained by the presence of ACE2 receptors expressed in neurons and glial cells of the brain, and neurological edema and brainstem compression secondary to the hyperinflammatory response. So let's talk again about colchicine. Colchicine is an anti-inflammatory drug that has been used in medicine since at least 1500 BC. We actually know of an Egyptian papyrus scroll that details the use of colchicine source plant Colchicum autumnale for pain and swelling. It was isolated in 1820 and received FDA approval in 2009, and it may be particularly relevant to the hyperinflammatory response created in moderate to severe cases of COVID-19. So there's a lot of mechanisms that colchicine could perhaps help. We see that colchicine especially dampens neutrophilic response via several mechanisms. Interrupts synthesis of microtubules, which aid in the movement of neutrophils. Interrupts traversing of vasculature, which is an important part of the neutrophil's contribution to the development of ARDS. It inhibits tyrosine kinases and phospholipases within the neutrophil, which are intracellular signaling molecules that play an important part in the inflammatory response. It inhibits lysosomal enzyme release during phagocytosis, which is a process that is normally used to destroy pathogens, but can be harmful during times of immune dysregulation like those in COVID-19. Colchicine inhibits calcium influx in the neutrophil, dampening neutrophil response, and perhaps of greatest importance, colchicine decreases cytokine production by interrupting activation of the NLR family pyrin domain containing 3 NLRP3 inflammasome, which in itself is an important product of pyroptosis and cause of inflammation. And so maybe you're asking, like, why does colchicine target neutrophils? Well, colchicine does that because neutrophils possess a lesser concentration of the intracellular pumps used to remove colchicine. So it works out really well, it seems, for COVID-19 perhaps. Alright, so you brave souls have made it through about half of the presentation. Stop, give yourself a pat on the back, and prepare yourself for some very technical review of the evidence. We're going to start with the method. So again, here's the research question. What are the effects of colchicine on the severity and mortality of COVID-19? So for the methods, a search was conducted from March 15th, 2021 to June 1st, 2021 using clinicaltrials.gov, EBSCOhost, and Google Scholar to identify relevant articles. Search terms used include colchicine, COVID-19, coronavirus 19, and SARS-CoV-2. For exclusion criteria, studies that didn't report the severity or mortality of participants or basic demographics between the study and control groups, studies or data in which patients were diagnosed with COVID-19 without confirmation via a positive nasopharyngeal polymerase chain reaction PCR test, and studies that were not in English. On our list here is by Tardif et al. And I apologize for the small text. I didn't want to break this up, but I'll read it all to you in case you can't see. So the study design was a randomized, double-blinded, adaptive, placebo-controlled, multi-center trial. It took place between March 22nd and December 22nd of 2020 at outpatient centers in the US, Canada, Brazil, Greece, South Africa, and Spain. And it had a total of 4,159 participants. To be included, patients had to be at least 40 years old, have had a diagnosis of COVID-19 within 24 hours of enrollment, not currently be treated in a hospital and or under immediate consideration for hospital treatment or admission, have at least one high risk factor. And I won't go through all those, but if you can't read them, I'm sure you know what high risk factors are for COVID-19, or you could look them up. Exclusion criteria included inflammatory bowel disease, malabsorption of the gut, chronic diarrhea, pre-existent progressive neuromuscular disease, a glomerular filtration rate, GFR, of less than 30, severe liver disease, current treatment with colchicine, current chemotherapy for cancer, a history of substantial sensitivity to colchicine. And as far as demographics go, the study group and the control group were very closely matched in age, race, BMI, rates of smoking, diabetes, hypertension, respiratory disease, prior MI, concomitant medication use, etc. The endpoints for this study were hospitalization and death. And so the colchicine group was found in this study to have lower rates of hospitalization and mortality than the placebo group. And you'll see asterisks by some of the figures in my presentation, and that means that those figures are of statistical significance. And so in patients with diabetes, the study found that the risk of primary endpoint, which was hospitalization and or death, was 6.1% in the colchicine group compared to 9.6% in the placebo group, even more pronounced in patients with diabetes. In patients with cardiovascular disease, the endpoints again were more pronounced compared to the general group. And worth noting, in women, the difference was negligible. Women in the colchicine group had a risk of primary endpoint of 3.7% compared to 3.5% in the placebo group. Moving on to the next study by Defteros et al. This was a prospective, open-label, randomized clinical trial that took place between April 3rd of 2020 and April 27th of 2020. April 27th of 2020, across 16 tertiary care hospitals in Greece. There were 105 participants, and to be eligible, patients had to be over 17 years old, hospitalized with COVID-19 confirmed by nasopharyngeal PCR testing, had to have had a body temperature of 37.5 degrees Celsius or greater, and 2 or more of the following: sustained coughing, sustained sore throat, anosmia, and agesia, fatigue and or tiredness, and arterial oxygen partial pressure lower than 95 millimeters of mercury on room air. For exclusion, patients either could have been pregnant or lactating, had a known hypersensitivity to colchicine, known hepatic failure, estimated GFR under 20, corrected QT interval of 450 milliseconds or higher, clinical assessment indicating that ventilatory support would be inevitable in the following 24 hours. And demographics between both groups were very similar with no statistically significant differences. So the outcomes for this study. In the control group, 1 patient needed BiPAP, 5 patients needed intubated, and 4 patients died. In the colchicine group, 1 patient needed intubated and later died. These differences were not statistically significant. What was statistically significant was the difference in peak median dimerized D-dimer, which was lower in the colchicine group, and that is an inflammatory marker. Differences in maximum high sensitivity cardiac troponin, maximum CRP, white blood cell, creatinine, platelet counts, GFR, and lymphocyte counts were not statistically significant between groups. Alright, so now let's talk about the next study here by Lopez et al. This is a randomized, double-blinded, placebo-controlled clinical trial that ran from April 11th to August 31st of 2020 at a hospital in Brazil. It had a total of 75 participants, and to be eligible, patients had to have moderate to severe COVID-19, as defined by the authors as fever, dyspnea, and imaging findings of pneumonia, and or the same findings plus respiratory rate greater than or equal to 30 times per minute or oxygen saturation below 93%. Patients had to be over 17 years old, had to have a body weight greater than 50 kilograms, normal levels of serum calcium and potassium, and a QT interval of less than 450 milliseconds. For exclusion, just for the sake of time, I'm going to spare you reading all of that, but I'm sure you can see it now, and if you'd like to look at it in more detail, you can review the article. And as far as demographics went, there was no statistically significant differences across many different variables and initial lab findings. The endpoints for this one were the time of need for supplemental oxygen, the time of hospitalization, the need for admission and length of stay in the ICU, the death rate, and causes of mortality. And secondary endpoints were the lab values that I mentioned. Let's see, actually I skipped those, sorry. Serum CRP, LDH, and the relation of neutrophil to leukocyte count from day 0 to day 7. So looking at the outcomes for this study, there was a statistically significant difference regarding the need for supplemental oxygen. By day 2, 67% of colchicine patients maintained the need for supplemental oxygen versus 86% of placebo patients. While at day 7, these values were even more pronounced at 9% versus 42%. Statistically significant differences were also noted in the duration of stay. 2 patients in the colchicine group and 4 in the placebo group were admitted to the ICU. The differences in the time of treatment before ICU admission and length of stay were very minimal, not statistically significant, and of the laboratory data collected, the CRP was statistically significantly lower than baseline by day 4 in the colchicine group, but it took until day 7 to reach that point in the placebo group. The other lab values were not statistically significant in the differences. Next article here is by Sandhu et al., and it is a prospective comparative cohort study that ran from March 21st to May 2nd, 2020 at a hospital in New York City, New York State. It had 112 participants. To be included, patients needed to be adults, have a positive SARS-CoV-2 nasal swab PCR, admitted to the colchicine floor upon obtaining permission, and have at least 2 out of 4 inflammatory markers recorded at least twice during the stay. Patients were excluded if pregnant, if they had end-stage renal disease, or concurrent use of a protease inhibitor, lamivudine, dolutegravir, tocilizumab, convalescent plasma, ketoconazole, cyclosporine, or clarithromycin. There were a few statistically significant demographical differences between the study group and control group. The colchicine group did have a higher temperature upon presentation to the hospital, did have lower rates of hypertension, diabetes, and renal failure, and a higher age. Rates of asthma, COPD, hypothyroidism, and coronary atherosclerotic disease, age, gender, and medication regimens were similar in both groups. The endpoints for this study were intubation, discharge, and mortality, inflammatory markers including LDH, CRP, and see here, ferritin. And so the colchicine group had a statistically significant lower rate of intubation, lower mortality, and a higher discharge rate. And all of the inflammatory markers showed a trend of more negative raw delta levels in the colchicine group, meaning the inflammatory markers went down to a greater degree, but only ferritin showed a statistically significant lower level in the colchicine group. All right, so moving on to Scarsi et al. This was an open-label prospective cohort study that ran from March 5th, 2020 to April 5th, 2020 at a hospital in Lombardy, Italy, with 262 patients, simple inclusion and exclusion criteria there. And there were a few statistically significant differences between the groups. The control group had a higher rate of malignancies, a higher PaO2-FiO2 ratio, and a lower ferritin and a lower CRP. So a mix of higher risk and lower risk factors there. Primary endpoint for this study was death. So for outcomes, the colchicine group was found to have a reduced mortality that was statistically significant, and Cox proportional hazards regression survival analysis indicated the lower risk of death was independently associated with colchicine treatment. Man, you would think that they could come up with shorter names for all these tests. All right, so our final study that was reviewed is by Brunetti et al. It was a propensity score matched cohort study from March 1st to March 30th of 2020 at a hospital in New Jersey. 66 were matched from a pool of 303 participants, and participants were included if admitted with a nasopharyngeal PCR confirmed COVID-19 and selected to be offered colchicine at the individual clinician's discretion. Demographically, the groups were very similar. There was only one statistically significant difference, being that there was a higher incidence of hypertension in the colchicine group. For endpoints for this one, the primary one was death, and the secondaries were favorable change in the WHO-OSCE score on day 14, the need for supplemental oxygen by day 14, and the same measurements by day 28. So the study here found that there were several statistically significant results, including a lower mortality, greater discharge rate by day 28, reduced need for supplemental oxygen by day 28, and a favorable change in the WHO-OSCE score on day 28 in the colchicine group. All right, so here is a table with the results summarized. I do have adverse effect data in this table that I did not have in the slides just for sake of time, but you are welcome to go back to the slide and look at it. And so, all right, you guys have made it all the way to the discussion. So we are on the home. So based on the studies reviewed, colchicine does have many clinical benefits on the severity and mortality of COVID-19 concerning both outpatient and inpatient settings. It was shown to reduce relative risk of hospitalization by 23.7% and mortality by 50% in outpatients with one or more high-risk factors. And for hospitalized patients, it was seen to reduce risk of mortality by 41.7 to 75%. Additionally, colchicine was shown to significantly reduce the duration of hospital stay, need for supplemental oxygen, need for intubation, and many clinical indicators of inflammation. And so these positive effects on the inflammatory markers support the notion that colchicine may reduce severity and mortality by exhibiting its anti-inflammatory effects on the hyperinflammatory state induced by COVID-19. All right. So other studies have supported the findings of this systematic review. A meta-analysis done found colchicine reduced the relative risk of mortality by 61.5%. Another meta-analysis found that colchicine was associated with statistically significant improvement of outcomes, including mortality and severity. But it is worth noting that Tardif et al. Found women as a subgroup did not benefit from colchicine, and unfortunately, the other studies did not report data between sexes within the study groups. Okay, so getting into some of the nitty-gritty here for limitations. So this review only covered 6 relevant trials with a total of less than 5,000 participants, and it's not unreasonable to prefer more data before drawing conclusions. Additionally, as we saw, many of these studies were not randomized controlled trials, and so they did not control a lot of the demographics between groups. That was 3 out of the 6. And this could have influenced the population slightly in favor of patients with better prognoses or worse prognoses, depending on the study and the criteria that they use to select patients. And take Brunetti et al., for instance, who selected patients based on the individual clinician's preferences, which could vary a lot. Additionally, the dosing regimens of colchicine varied between the studies. However, I do want to point out that every study reviewed found a statistically significant or nearly statistically significant benefit across many different outcomes, including severity of disease and mortality. So as far as risks go with colchicine, the most common adverse effect recorded was diarrhea, which was experienced by 7.6 to 45% of patients. And we know that this is a common symptom of COVID-19, but it's also a well-known side effect of colchicine. But these GI side effects were not serious and did not increase risk of dehydration. Tardif et al. Did find more pulmonary emboli in those taking colchicine, but ultimately this did not negatively affect disease course or mortality. Additionally, a previous study done with over 10,000 participants over 2 years didn't show any association between colchicine and pulmonary embolism. This particular adverse effect could have been from the hypercoagulable state induced by COVID-19, but this risk should be monitored carefully. Previous studies of colchicine demonstrate a very safe profile. And so for implications, it seems to be a very promising treatment for COVID-19, perhaps the only available treatment that can be prescribed and taken orally outpatient. Many areas of the world we know still lack access to COVID-19 vaccines and adequate medical supplies to support patients with moderate to severe COVID-19. Colchicine is relatively cheap. It's very widely available, very well studied, and easily administered. Especially in countries that lack an abundance of resources, colchicine should be strongly recommended to help reduce pandemic burden. Many other studies investigating the efficacy are actually underway, and there will likely be a more clear role for the drug by the end of 2020. All right, so I've outlined some guidelines here, and I'll summarize them. For outpatients in countries with adequate resources, patients who are at higher risk with COVID-19 confirmed by a PCR swab should be offered colchicine and have the prospective benefits explained to them, along with the risks and the developing nature of research. For inpatients hospitalized for COVID-19 in all countries, I think that unvaccinated adults diagnosed with COVID-19 without contraindication should be offered colchicine with the explanation of potentially improved disease course, told about the side effects and the developing nature of the drug. Use in patients with an inability to make decisions should be at the discretion of the medical provider and responsible power of attorney. For all patients in countries with more limited resources, I think that colchicine should be recommended in unvaccinated adults. I think that this could be really, really helpful. And so for recommendations for future research, I would say that there's arguably enough evidence to implement colchicine now. I mean, phase 3 testing has been completed and looks good. But research shouldn't stop here. More double-blinded, placebo, randomized controlled trials should be conducted. And I think that we should look at the gender differences and the optimal dosing regimen, and also investigate the pharmacologic dynamics that cause the beneficial effects, because understanding those better might help us understand this hyperinflammatory response better and lead to better treatment. So in conclusion, SARS-CoV-2 is a virus that has infected over 185 million people globally, taken over 4 million lives, unfortunately, and affected the daily lives of billions of others in myriad ways. And not a lot of great treatment options exist right now or are available across the globe. And this hyperinflammatory state induced by COVID appears to be at the heart of most moderate to severe cases. And so this systematic review set out to determine the effects of colchicine, which is a well-known anti-inflammatory drug, on the severity and mortality of COVID-19. A total of 6 trials were reviewed, all of which showed benefits to severity and mortality, and adverse effects were nearly exclusively non-serious GI manifestations. More data is needed, but given the desperate picture of the pandemic internationally, colchicine should be considered according to the guidelines suggested in this review. So thanks for your time, guys. I hope you enjoyed this and learned a thing or two. Here are my references. Have a good day, guys.